Hello everyone, this is Ceyda Akartuna. I'm a medicine resident at St. Elizabeth's Medical Center, Brighton. I will be presenting a case of cardiogenic syncope with coexisting atrial lipoma and lipomatous hypertrophy of the interatrial septum. Patient is a 73-year-old woman who presented to the emergency department after a motor vehicle accident. Upon further questioning, it was found out that she had a pre-syncopal event while driving. She did not have any past medical history or other pertinence in her social or family history. Her physical examination was quite unremarkable, except for tachycardia with her heart rate up to 150 beats per minute at times. Electrocardiogram revealed atypical atrial flutter and multiple premature ventricular complexes. Blood work, including complete blood count and a metabolic panel, were all within normal limits. Her cardiac enzymes were trended and remained negative. She underwent imaging of her head, which was negative for any acute intracranial events. Eventually, a CT angiogram of the chest for concern for pulmonary embolism was done and revealed the large mass that you can see in Figure 1. Overgrowth of lipomatous tissue was also noted in the interatrial septum in this study. This was followed by a transesophageal echocardiogram, which further confirmed the lipoma attaching to the right atrium and lipomatous hypertrophy of the interatrial septum compressing the superior vena cava. Cardiac MRI further characterized the lesion, including the dimensions of the lipoma that were 5.4 to 4.8 centimeters in the axial and 7.2 to 5 centimeters in the sagittal planes. Patient was consulted with cardiac surgery and was planned to follow up with them in the outpatient setting. She was to undergo right heart catheterization to evaluate the pressure gradient between the right atrium and superior vena cava. A cardiac telemetry monitor was also arranged for her to evaluate the arrhythmia burden. Unfortunately, patient did not follow up with the scheduled appointments, and none of these studies could be obtained. For the discussion part, I will start by briefly describing these two entities. Both are overgrowths of cardiac adipose tissue. The difference between them is the presence of the capsule. Lipomas are encapsulated, therefore readily separated from the surrounding tissue. Whereas lipomatous hypertrophy of the interatrial septum is an infiltrative lesion intertwined with the normal cardiac tissue. Both conditions have been described to present with arrhythmias and circulatory obstruction as with our patient. Presence of symptoms frequently necessitates surgical intervention in these cases. Resection of lipomas are relatively uncomplicated owing to their encapsulated nature. However, lipomatous hypertrophy of the interatrial septum requires a more complicated surgical approach. To conclude, with today's advanced imaging techniques, these entities are more frequently recognized, and they should be, as accurate diagnosis is crucial for appropriate management and better outcomes. Thank you very much for your attention.